Hi, this is Chris Houston. I'll be doing my journal club number 3. The title is Galcanezumab in Prevention of Episodic Cluster Headache. It was published in the New England Journal of Medicine. For a little bit of background on cluster headache, it's a debilitating primary headache, and sufferers will usually see a symptom onset of the third or fifth decade of life. These symptoms include rigorous pain behind the eye or near the orbital, lacrimation, rhinorrhea, ptosis, and nasal congestion. Men are approximately 4 times more likely to experience cluster headache, and there is an association with history of smoking, either quit or currently smoking, and the symptom onset of cluster headache. Current abortive therapies include supplemental oxygen, serotonin receptor agonists such as sumatriptan and zolmitriptan, sub-Q injection and nasal spray respectively, and to a lesser degree lidocaine nasal spray and sub-Q octreotide. Additionally, prophylaxis can include betamethasone injections, by-mouth calcium channel blockers, including verapamil, as well as lithium and warfarin and melatonin as well, but to a lesser extent and with less robust data. Some of the investigative therapies for at least migraine prophylaxis and migraine treatment have been calcitonin gene-related peptide antagonists, such as arenumab, and receptor antagonists, that is CGRP receptor antagonists, such as galcanezumab and fremanezumab. The registration for this trial took place in 2015. The actual study was completed 06/04/2018, and the first results were published in March of 2019. The study was funded by Eli Lilly and Company, and interestingly, on the clinicaltrials.gov, there's a statement about the principal investigators not being employed by Eli Lilly. However, there were 2 manuscript writers that essentially created the trial, and one of them was employed by Eli Lilly, purportedly injecting some bias into the trial itself. So this was a phase 3 trial investigating safety, efficacy, and dose. It was international in the United States and numerous countries in Europe, and it was multi-center, included 35 sites in total. It was double-blind, so blind to the participant as well as the investigator, and it was a modified intention to treat population. There was a screening period prior, as well as a baseline period leading into the 8-week double-blind placebo-controlled period for the trial. Additionally, there was a 4-month washout period where the participants were continued to be studied. However, that has not yet been published. Assignments were fairly even across the placebo arm and the experimental arm, with members of each also being split up into headache attacks either less than or equal to 4 per day or greater than 4 per day when they were having a cluster headache attack. So the inclusion criteria was essentially a diagnosis by the International Health Society of International Classification of Headache Disorders of cluster headache, and then participants had to be able to differentiate between different types of headache. So they had to be able to differentiate between cluster headache and migraine, for example. For the exclusion criteria, if they had been involved in a previous clinical trial within the last 30 days, or had been exposed to another calcitonin gene-related peptide, or if they were taking indomethacin, if they were confusing migraines with cluster headache, if they had a presence of mental illness prior to this, because some people that experience cluster headaches, the pain for them is so severe that they will think about suicide. And finally, no women who were pregnant or breastfeeding were allowed in the trial. So for the experimental group, the 2 arms were galcanezumab, 300 milligrams sub-Q every 30 days for an 8-week treatment period. So essentially they would have received 2 doses. And then placebo, which was also sub-Q every 30 days. Interestingly, the a priori sample size calculation came to 162. However, the actual enrollment that was allowed was 109 participants because the people that were in the trial had to be experiencing a cluster headache attack during the period of the trial. The primary outcome was the overall mean change from baseline in the weekly frequency of cluster headache attacks across weeks 1 through 3 after receipt of the first dose, and the key secondary outcome was the percentage of patients who essentially dropped from their baseline by 50%. And there were 10 other secondary outcomes as well. For the statistical methods for the primary, they used a least squares mean and they got a p-value of 0.036. And for the secondary, they used as cautious non-parametric randomized based ANCOVA, and they came up with a p-value of 0.046. They also used a gatekeeper strategy to ensure that their sample size was large enough so they could actually determine statistical significance, and that was the case. There was no issue there. Some of the biases that I wanted to point out is that one of the investigators was actually, excuse me, one of the manuscript writers was employed by Eli Lilly, and there were no signs that the outcome assessors were blinded. It was only double blinded, not quadruple blinded. And then with the modified intention to treat analysis, a per protocol analysis would have been more conservative in their results. However, the modified intention to treat analysis is more akin to what you would see in real practice. So the baseline data for the participants, the average age was about 46. Most of the participants were predominantly Caucasian. In fact, around 80 to 90% were Caucasian. They were split evenly between former smokers and current smokers. And there were many more men than there were women, which is in line with the pathology of cluster headaches to begin with. And for missing data, if there were any more than 4 days not inputted into an electronic diary, then the remaining data was used to calculate an average for the symptom days for cluster headache, and then people that were lacking a substantial amount of data in their diary were considered to not have a response to the active drug. Additionally, sensitivity analyses were conducted to ensure that that change in dropouts or missing data were not sensitive to the statistics that were shown in the trial. And that was in fact the case. They were not sensitive. For the primary outcome, the experimental group getting Galcanezumab, their symptoms decreased by a frequency of about 3.5 with a p-value of 0.04, and the secondary outcome, there was about an 18% greater reduction in patients receiving a greater than 50% reduction in cluster headache symptoms in the experimental group compared to placebo, and that had a p-value of 0.046. The adverse side effects were minimal, basically just injection site reactions, and the Galcanezumab group, more of them developed a fever, but that was only 4% compared to 2% in placebo. The author's explicit limitations included that change in sample size that was necessary because of the factors surrounding the pathology of cluster headache, and then their change in power had to be calculated post hoc as opposed to being set a priori. And they wanted a longer trial period as well, since essentially the people in the trial only received a couple doses. And as we'll see, the difference was not very substantial after week 4 or after week 8. For generalizability, it's somewhat sparse because it does include only Caucasians, essentially. However, the male to female ratio does match what is commonly seen in cluster headache, and the modified intention to treat analysis seemed to be appropriate for matching what you would normally see in practice. My interpretation of this trial is that the change in sample size really worries me. I understand that the conclusion was logical to do so because of the people in the trial needing to be in a cluster headache episode or attack during the trial period. However, the fact that they changed from an a priori calculation to a post hoc calculation does worry me and does seem to limit the overall efficacy of their results. And for their primary outcome of major note, at 3 weeks, that was their primary outcome. However, the decrease in the number of attacks seen for the participants getting the experimental treatment was exactly the same as placebo by week 4. And then through week 8, placebo actually increased in diminishing symptoms and diminishing attacks as opposed to the actual treatment group. Besides that, a same story can be seen in the secondary outcome as well, where eventually placebo was as good, if not better, than the actual Galcanezumab treatment group. So with this, I take this trial with a large grain of salt. I think it is a step in the right direction because there are so few available treatments for the prophylaxis of cluster headache. However, the fact that the drug only seemed to work 3 weeks or so gives me great pause.